be able to engage the straight garrison. So that is a problem that I face here. Okay. You will see.
You have an abdomen probe to go to the component.
I don't think that would be possible here because the entire orbit is sunk. And what I would like you to appreciate at this point is this anatomy of the bone and how it turns around. Can you see this curvature? So initially when you are punching, initially, so let's put this mucosa back. So in live surgery this does not happen. So initially when I was punching, this bone was all vertical. Now as I start going higher up, can you see this becoming more horizontal? Yes? So that is actually the highest point. Now at this point, now if I am not able to engage the angle or the curve DCR burr, the next thing is to probably drill this bone with a small polishing burr. Now once again at this point, I would like to put that flap back and show you why we go so high up. Can you see this? Now see where the axilla is. This is where the axilla is. And now see where they have gone. So we are not making an opening down here. You see the distance where they have gone higher. And can you appreciate the upper part? So in the upper part, the sac will be much more broader. So ideally, I would like to punch out all these and have all these edges polished. And this is the kind of exposure I would like to have for my DCRs. Can you see that? So I raise the uppermost portion of the sac. Yes or no? Okay? So as you come down, the sac tapers. So the uppermost portion is the broadest area. So sometimes this bone is very thick, you will have to drill it out also. So you can't go with the thought that you can manage all these cases to the garrison. So the pneumatization, the thickness of the bone varies. So I would like to make these edges of the bone as flat as possible, as polished as possible, because my flaps will lie on this. Okay, so you have to get it flush. You have to almost. So these are all the fine points that you need to look into when you work DCR. Is that clear? Any doubts so far? So this is the anterior wall of the sac. I am almost flush there. So I have taken sufficient enough amount of bone. Now at this point you can either probe it. Yeah, we will be using a probe here, so you can probably see, this is a multi-layered structure, so you can give some infiltration. It has a couple of layers. So the next common mistake is not going through and through all the layers. So you incision only the superficial layer and then try looking for the lumen. So it has two layers. You need incision go through and through. Again, be careful that you don't go across and damage or make an incision across on the opposite side also. Okay. So ask the assistant, you can probably pass a probe. You can tend it with a probe. Now the knife that you use should be a fresh sharp knife. This is a sickle knife. So this is what I was talking about, the layers. Can you appreciate this one layer through which we have put an incision? Okay. So the incision, generally I prefer
a number 11.
11 number, yes. Or you have this DCR knife. So can you see that? Now we are opening up into the lumen. Okay. And the whole idea is to create two. We have to create two flaps. Now this press again. Can you appreciate that now?
Yeah.
That is the lumen. So this will be the posterior flap, whereas this will be the anterior flap. Can you see that? So expect the incision all the way. So normally in a live patient, what happens is if there is an infection, you will find mucopurulent discharge coming out. Okay? And now if you just make these and leave it, it's not going to work. The flaps will fall together. So the next option, I think have a right system here, I guess. So if you have a small DCR system, what you can do is you can make a small cut superior. You can see that a releasing incision. Similarly, another releasing incision here. So what happens is that so you can use a small terminate knives for this purpose, and subsequently what you can do is you can reflect this posterior flap backwards. Can you see that? Yes? Subsequently, what you do is, subsequently what you have to do is the same thing with the anterior flap. So with the anterior flap, we have something called as a DCR knife. So that is basically a blade which cuts anteriorly. So with that, I'll just make a cut here and I will make another cut here so that this anterior flap breaks over this bony edge. Is that clear? Okay. And ideally, what you should be seeing at the end of the procedure is your common canalicus. So the reason why you want to go higher is the common canalicus. Okay. Now here obviously you will not be able to see it's kind of smudged. I can't reach it, otherwise what I've drawn in forces. Let me see if I get this down. So can you see the membranous, the bluish membranous kind of thing there? That should be the area where you have the will not be able to demonstrate that in this. Okay. So this is how large the opening should be. Is that clear? And subsequently what you do is you can reposition your flaps back. Now how do you reposition your flaps? So when you reposition your flaps back, they should not be obscuring your view, the opening that you have created. Now you have a look where you are here. So what you can do is you can split this flap. Okay? Now the advantage of keeping the flap is that it heals quicker. Yes? You can cover the superior part. Okay? So you can divide this still more. Now here, because we don't have the uncinate, this flap will be hanging, normally it's attached to the video, okay? And this part will cover the lower part. Okay, fine. And this part goes up. So make sure that you cover as much of the raw areas as possible. And keep the edges inverted. Is that fine? Okay?
Yes.
Any doubts?